As a reminder of what we were doing yesterday, so yesterday we were looking at the osteoanatomy of the pelvis. So the pelvis is made up of two hemipelvis. The pelvic girdle, is made up of two hemipelvis plus a sacrum at the posterior part in the middle of them. So today we are going to look at the hemipelvis. So for this lesson, I would like us to know the different parts of a hemipelvis, and then I would like us to differentiate between a male and a female hemipelvis. So we are going to start with the parts. So you can divide it either according to the parts that make it up, or you can divide it structurally. So structurally, the pelvic girdle is divided into two by the line which we call the line of Allah, which is a margin that runs along the whole pelvic girdle. But for one hemipelvis, we call it the actuate line. So it will divide it into the false pelvis, which is located superiorly, and the true pelvis, which is located inferiorly. So the false pelvis mainly has the ilium, and the true pelvis has got the pubis and the ischium. So we are going to look at different parts of this pelvis. So we'll begin at the ilium. So at the ilium, at the very top of the ilium, because it's at the top, we'll call it the crest of the ilium. So as you can see this part, this is the crest of the ilium. So the crest of the ilium is divided into two sides by a line, which we call it the intermediate line, that divides it into the inner lip medially and the outer lip laterally. So the line divides it all through. So at the ilium we also have spines. So anteriorly we'll have the superior anterior iliac spine and the inferior anterior iliac spine. Posteriorly we'll have the superior posterior iliac spine and the inferior posterior iliac spine. So when you look at it from the posterior aspect, this is the gluteal aspect of the ilium. So this surface is called the gluteal surface. So along the gluteal surface, we have margins which are there. So if you look at it from the posterior, these are not seen. So if you look at it on the posterior surface, we have the posterior gluteal line, and then we have the anterior. I think you can all see. We have the anterior gluteal line. It's drawn here, and then we have the inferior gluteal line. So if we try and follow it as it comes that way, so if you follow the ilium towards the ischium, you'll meet a notch there. So this one here is the greater sciatic notch. So then as you come downwards, you'll meet another spine. So because you are on the ischium, we'll call it the ischial spine. Then after that spine, there's another notch, which is the lesser sciatic notch. Then now we have the ischium. You'll now meet the tuberosity. So this one is not the ischial tuberosity. Then it has the ischium only has got one arm. An arm in Latin is called ramus. So this arm is the inferior, because it's located inferiorly. It's called the inferior ramus of the ischium. It connects to the inferior arm of the pubis. Then this is now the tubercle of the pubis and the anterior arm of superior the arm. So I think you have at least realized most of the parts, right? So next I'm going to look at the divisions that make up the four parts, the ischial tuberosity. Okay, so today we are going to look at the ischial tuberosity. So the ischial tuberosity is located at the base of the ischium. So it has got four main compartments, which are divided by the vertical and oblique ridges. So when you look here, we have the boundary between the ischial tuberosity and the upper part, which now the lower part will now be the ischium. So the ischial tuberosity begins at this boundary. So if you look carefully, we have got these two attachments here, and then there is a vertical ridge separating them. So this vertical ridge here will form the attachments for the long head of the biceps femoris and the semitendinosus. Then on the lateral side, we'll have the semimembranosus attachment. So then we have the oblique ridge running here, which will now give us the upper region of the ischial tuberosity. Now on the lower region, we'll also have the vertical ridge giving us also the medial compartment and the lateral compartment. So on the medial compartments, what you expect to touch are basically fascia, the bursa, and mostly fat. Then here we'll have the long head of the adductor magnus. Have this hole here. This hole is the obturator foramen. So normally it usually has a membrane in a living human being. It has a membrane called the obturator membrane. And just above the membrane there's a space. Can somebody remind the name of the space? The obturator? Groove. So because it's a space here, it's usually here. So the obturator is usually an opening just above the obturator membrane. It allows the passage of vessels and nerves, right? So, and this other hole here is called the acetabulum. So if you look at the acetabulum properly, this hole, so if you look at the acetabulum, it has a smooth surface and a rough surface in it. So you can see. So the smooth surface, we call it, you just remember, when you hear smooth, remember of the moon. The moon has a smooth surface. So we'll call it the lunate surface of the acetabulum. And the rough surface is now a hole, because you realize it's much deeper, so we'll call it a fossa. And it even has got some rough holes in it. And then there is this other part, there is this part here. So when you see this part of the acetabulum, it's like a lip of the acetabulum, just like your lips. So the other name of the lip is labia. So we'll call it labrum, the labrum of the acetabulum. This one here, it's like your lip, the lip that is on your mouth. So we'll call it the labrum of the acetabulum. So, and then if you look at it, the top part, as I told you, the top part of our region, we'll call it a crest, because it's coming at the top. So as it comes toward the top, this is now the crest of the acetabulum. And on top of the crest, there's another margin. We call it the margin of the acetabulum, right? So I think I'm done with the parts, unless I've forgotten something. Sorry? There's this space here, this opening here. This is now what we call the acetabulum notch. So as for today, we're just focusing on parts. As we advance later, we might explain to you further about the different nerves, muscles, and what have you. So now the next we are moving to differentiating. Yeah? Sorry? The groove. This one. The foramen. Okay. Any other thing? Yes. So as I was explaining to you, this is the pubis, this part that leads the tuberosity that you see here. So this is the pubis. This is anterior aspect of this region. So as you can see, this pubis, it has got two arms, the anterior arm, the superior arm and the inferior arm. So the inferior arm is what we call the inferior ramus. Ramus is just another name for arm. So the inferior arm of the pubis, it connects with the inferior arm of the ischium. So they join together to form the pubio-ischial ramus, or the pubio-ischial arm. Anything else? Sorry? I didn't get you. The symphysis is at the center. The surface, this one. Yeah, this is not the surface. Now, when it usually has some membrane here that connects to the other pubis. A ligament, sorry. So next we are going to differentiate. Sorry.
So today we are going to discuss about the inner or this is the inner. Just understand. Just the outer and this is the inner. So this, according to siding, this is the posterior side, because this is where it articulates with the sacrum. So this is the place that articulates the sacrum. So this is the posterior side and this is the anterior side. So we are going to talk about the inner part of the pelvis. So here we have this depression here. This is called the iliac fossa. Iliac fossa. Fossa is just a cavity. Iliac fossa. So again here, where it articulates with the sacrum, we have like two parts. These two parts, we have this part which is somewhat like a protrusion. So this is called the iliac tuberosity. Iliac tuberosity. And we have this surface here, which also forms the junction of the joint of the pelvis and the sacrum. Can you see it looks like an ear? Auricle. So it's called the auricular surface. So these names are mostly originate from the shape, like the maybe Latin word or the Greek word and so forth. This one, they named it the auricle. So it's not like an ear. So this is the auricular surface. Something else I think we didn't talk about here. When you go and when you see the anterior superior iliac spine, when you go 5 centimeters towards up the iliac crest, you get this tubercle. So this is called the tubercle of the iliac crest. I think there's not much about that. Maybe touch on this is called the nutrient foramen. It's also here, nutrient foramen. And also we didn't talk about the nerve. The nerve that passes here is called the treta nerve. And also the thank you for listening.
If you have been given only one hemipelvis and they ask you to differentiate, there are factors which will make you to differentiate quickly. So first of all, we'll begin with the ischium. The ischium. So when you place it in an anatomical position, I'm doing this for the video. So when you place it in an anatomical position, whereby the ischium is facing you directly, so you look at the outer surface. Look at my hand. So there's this, and there's this. So if it's more of this, it's for the female because it's pointing outwards, it's pointing laterally. If it's pointing inward, it's most likely suggests that it's most probably a male pelvis. If it's pointing downward, you might have to look for other features because it's not definitely female, not definitely male. So there, for the female and male pelvis, we are basically looking at two types. So there are about 5 different types of pelvis, but we're looking at 2 main pelvis. Just imagine that it's like 2 things on a continuous line, whereby each end is showing the distinct opposite of the other. So when we say the male pelvis, this is a pelvis that supports male characteristics, while a female pelvis, it supports female characteristics. So the female pelvis is also called the gynecoid pelvis, while the male pelvis is also called the android pelvis. The others are intermediate. These other types are intermediate because they are neither too female or too male. They could have combined properties. You understand? Okay, so for the female pelvis, if you are using the bone to differentiate, but if you are using theory, there are about 15 different parts. So the first part, we look at the ischium. We look at how it's pointed. If it's pointed outward, it's most likely female. If it's pointed inward, it's most likely male. So if you're given 2 of them at the same time, the other thing that you can look at, apart from comparing, because you see, if you are to compare these 2 in an anatomical position, so you will realize that when you do it this way, that the male is pointing more downward than this one, which is pointing more laterally. It's open this way, this one which is downward. So the other thing that you can compare with is the obturator foramen, this opening. So for the female pelvis, you'll realize it's more of triangular, but for the male pelvis, you'll realize it's more of round. That is if you're looking at 2 of them, because you can also be told that the female pelvis is also more of oval than the male pelvis, because the triangle shape assumes more of an oval shape, right? But generally, if you're also looking at the sizes, the male pelvis obturator will be larger than the female pelvis. The other one is that if you're given 2 parts, you can also look at the acetabulum. So the male pelvis will have a larger acetabulum than the female pelvis. That is if you're comparing of the same age, people of the same age, right? But if you're given one, there are distances. If you have like a piece of paper, you can measure the distance of this anterior arm, the superior arm of the pubis, the superior ramus of the pubis. So if you look at this distance, you compare to the distance of the acetabulum. So in a female pelvis, this distance will be larger than the distance of the diameter of the acetabulum. But in a male pelvis, they will either be similar or the one of the acetabulum will be larger. So if you look at this arm, for example, so this arm will either be the same distance or the acetabulum will be larger, like in this case, right? So the other difference that we use is the great sciatic notch. If you're only given one piece, so you can look at the great sciatic notch and you look at the angle. So in a female pelvis, this angle is usually about 90 degrees, while in a male pelvis, it's usually 70 degrees or less. It's usually more acute than the female pelvis, the angle of the great sciatic notch. And then the other things that you can look at, if you're given two of them, you can compare the width of the false pelvis. So you'll realize that the width of the false pelvis is usually shorter in the female, while it's usually longer in the male, right? And then also the weight. In a female pelvis, the pelvis will be lighter, while the male pelvis will be heavier. That is if you are given two to compare, right? And then so these factors such as the width and the weight can be classified further into different regions. So you can start looking at the iliac crest. You can say that this crest will be heavier in a male than in a female. It's just general aspect. But I think those are the main points. But if you look at the theoretical points, there are more. There are about 15. So for this video, I'm focusing on the anatomical differences, which you can tell by looking. Does anyone else have any additional points?
Does the thickness of a bone tell us if it's female or male?
No, if you've been given two, it will be easier, like
Compare.
yeah, generally. But no, you see, it's also relative to the person. If it's a female who is going to the gym, they may develop thicker bones to support the weight. The thickness is only to support the weight. But that's why I call them relative comparisons. For the anatomical, I would rather go with those that are more objective, like now the acetabulum and those that I've mentioned earlier. I think that's clear. And cut.
Thank you.
In this lesson, we are going to look at the anatomical significance of the pelvic girdle. We shall begin with the ilium. So first of all, we are going to begin with the ilium. We have underlined. So the ilium, it's the largest part of the hip bone. It transmits body weight from the spine to the legs via the sacroiliac joint, and it also provides surface for attachment of muscles, like posteriorly the gluteal muscles attach. Also, it forms part of the acetabulum at the hip socket, and it also helps to protect pelvic organs. Also, the iliac crest, this region here, the top part, is usually a landmark for clinical procedures such as in biopsy. That is an example in bone marrow aspiration. So next you are going to look at the acetabulum. So this is the acetabulum as it's pointed there. So we'll first of all list the structural significance, the functional significance, followed by the clinical significance. So for the structural significance, so it's the socket of the hip joint. So basically you expect the head of the femur to articulate with the acetabulum. So it's formed by the fusion of the three pelvic bones, that is the ilium, ischium and the pubis. So it has got the articular notch, which is an incomplete portion of the inferior margin, which allows the passage of vessels and nerves. So also there is the acetabular labrum, which is the lip of the acetabulum. As you can see, it's here, as I'm going to point to you. This region that you can see here, which I also highlighted in our earlier video. So this acetabular labrum is a fibrocartilaginous rim that deepens the cavity, improving stability. So it helps to improve stability of the bone which is articulating there. So for the functional significance, you realize that it assists in weight bearing, in the mobility and stability of the structures beneath. Now, like the lunate surface of the acetabulum is soft to assist with the mobility. So it also assists in load distribution because it's located laterally. So in both lateral ends, it at least distributes the weight evenly, the weight of the body evenly. So the clinical significance is in hip dislocations. It's even though it's rare, the acetabulum, it's usually one of the regions that is affected when there is a hip dislocation. So also fractures, So fractures of the acetabulum, they usually disrupt or impair the weight transfer of the hip region. Then in arthritis, so some patients who suffer from osteoarthritis, in complications, it's usually of clinical insignificance because it will be modified with an artificial plate. Also, we are talking about hip dysplasia. So it's the shallow acetabulum fails to cover the femoral head adequately, leading to instability. So in some cases, you might find that there is instability in a human being. Okay, so next we're going to look at the obturator foramen as it's shown here. So in living people, there's usually the obturator membrane, as we stated earlier, with an obturator groove, where you'll find there is passage of three main structures. There's the obturator nerve, the obturator artery, and the obturator vein. So its other structural significance will be the fusion of the arms of the ischium, that is the inferior ramus of the ischium and the inferior ramus of the pubis. So next you're going to move to the ischium. So the ischium, it forms part of the hip bone and supports body weight when sitting. So it contributes to part of the acetabulum. It serves as an attachment point for muscles like the hamstrings and ligaments. So the ischial tuberosity is a key sitting bone. That is what you sit on. So the ischial spines are important landmarks during childbirth. So the ischial spine is at the back here. So it's an important landmark during childbirth. So clinically, it's also relevant for fractures, bursitis, and pressure sores. So because of like this ischial spine, when you're sitting down for long, it will pierce you and you'll feel pain. So it can create pressure sores in a patient who is not mobile. So next we're going to look at the symphysis, the pubis, and the coccyx. So with the coccyx, this one here, so for the coccyx, it supports the pelvic floor muscles and it also aids in childbirth. It also helps in sitting and balancing. So the pubis is the one that is located anteriorly, this one here. So it's also an attachment for the pelvic floor muscles, the projection of organs, and it forms part of the hip joint. So the pubic symphysis, not this one here. So there's usually a ligament which attaches that forms the other hemipelvis. So it's a fibrocartilaginous joint allowing slight mobility. Let me repeat that. It's a fibrocartilaginous joint allowing slight mobility, vital organs, and stability during childbirth. So during childbirth, you'll find that this part will slightly enlarge, allowing the passage of the fetus. So next, you're going to look at the arcuate line. So the arcuate line is usually a line which is usually part of the line of Allah, but not the hemipelvis. We'll call it the arcuate line. So the arcuate line will start with the structural significance. So it's a smooth line that is found on the interior aspect or the internal part of the pelvis. So it usually forms anatomically. So it forms a separation of the true pelvis and the false pelvis, whereby the top part above the arcuate line is what we are calling as the false pelvis, while the lower part is the true pelvis. So anatomically, you expect to find other muscles such as the rectus sheath, which are usually a landmark during surgery. For example, if you want to do partial TAH, whereby you are sparing the cervix, so it can be a good landmark. So the clinical significance is that in obstetrics, the arcuate line helps in increasing the pelvic inlet size, and is important during childbirth. So for surgery, I studied it's a clinical significance, and also in imaging anatomy. So it differentiates the pelvic arcuate line and the rectus sheath. So the last one that we're going to look at is the sacrum. As you can see, the sacrum is the one that just comes after the lumbar vertebrae. It's now the vertebral part within the pelvic girdle. So first of all, we're going to begin with the structural significance. So it forms the keystones of the pelvis, transmitting weight to the upper part of the body. It contributes to the stability of the pelvic girdle because it articulates the two hemipelvis. So it helps to maintain an upright posture. So for articulations, of course, as I explained earlier, it articulates with L5 and laterally with the two hip bones. Those are the two hemipelvis. And inferiorly, there's the coccyx. So the anatomical landmarks, so for the anatomical significance, it forms landmarks for the sacral proximity. So there's the sacral foramina, which are those holes that you can see, these holes here within the sacrum. So these holes are usually important openings for passage of sacral and spinal nerves. So the median, intermediate and lateral sacral crests. Next, we are going to the neurological significance. So it houses the sacral nerve roots, that is S1 to S5, because it's still part of the vertebral column. So if you look at this region, the entire region, you'll find that the S1 to S5 will be there. Those are the column, the nervous parts from that will be moving from S1 to S5, or the sacral vertebrae in short. So next for obstetrics is so the sacral curve forms part of the childbirth canal. So for obstetric importance, the sacral curve, it forms part of the birth canal. That's important. So the last one, we are going to look at the clinical significance. So it's a common site for stress and fractures, mainly at the sacroiliac joint. So the sacroiliac joint, so between the sacrum and the ilium, this joint here. So you'll find a fracture happening there because it's a fusion. So it's a landmark for epidural and spinal anesthesia. So if you want to administer anesthesia, you'll administer it, you'll palpate it before you go and palpate the L2 and L3. So you'll first of all feel for it and then you'll palpate upwards. I think I've already mentioned it. It fuses here. The L5 fuses with the sacrum there. So it's called sacralization. So it fuses.